My name is Mark Lobbes. I'm a dedicated breast radiologist at the Zuyderland Medical Center, which has two locations in Sittard-Geleen and Heerlen in the southern parts of the Netherlands. I've been practicing breast imaging as a radiologist since 2011, and my main areas of interest are contrast-enhanced mammography, which I've been implementing in everyday clinical practice since 2012. And my main areas of expertise and research are trying to implement contrast-enhanced mammography as a really certified imaging tool in everyday clinical practice. So contrast-enhanced mammography is a new type of mammographic examination. It has quite some similarities to conventional mammography. So the patient still needs to be positioned between two compression paddles. But before we do the image acquisition, we administer contrast through the bloodstream in a similar fashion that we're used to for using, for example, in CT examinations. So we're quite familiar with those protocols. Now, after 2 minutes, the patient is placed between the compression paddles, and the machine itself does not take one image, but in quick succession it takes two separate images with a different energy spectrum, but that's a little bit of a technical story behind that. But it allows us as a radiologist to not only look at the normal mammogram, but it also provides us with what they call a recombined image. And that's an image in which areas of contrast uptake can be visualized. Well, these areas of contrast uptake are suspicious for breast cancer, but not really a proof of breast cancer, because there are still many other benign structures that can also cause enhancement. But at least it should be triggered to the radiologist that there's something of relevance going on right there, and it should be further investigated, for example, with targeted ultrasound. During the years, we have more extended the indications for which we use contrast-enhanced mammography. At first, when I started to implement contrast-enhanced mammography, I chose to reserve it for the recalls from breast cancer screening because I thought there was already a higher chance of detecting breast cancer in those women, and that would sort of justify for me the use of iodinated contrast agents and also the slight increase in radiation exposure for those women. Now, with time, we grew more and more confident, and more scientific literature was becoming available from different groups as well, and that's the reason why we right now have not only the recall evaluation from women that are referred from screening, but also preoperative evaluation of breast cancer extent. Where we used to do breast MRI, we now do a lot of contrast-enhanced mammography for that indication. But you can also think about response monitoring in women treated with neoadjuvant chemotherapy. That's also a big terrain of breast MRI before, but more and more evidence is occurring that you can use contrast-enhanced mammography for that indication as well. Now, the benefit of contrast-enhanced mammography is that it's easy to use. You can implement it in your own mammography suite almost directly after you see the patient for the first time, and that allows us to do all the necessary biopsies, not make separate appointments to breast MRI, and it allows to make our workflow more efficient. For example, when we look at the way we practice it in the Zuyderland Medical Center is that when a patient has a suspicious palpable mass, we do a targeted ultrasound at first, and if we see some solid mass or something that is highly suspicious of breast cancer, we immediately perform a contrast-enhanced mammography because we also want to do the preoperative staging as well. Even if we have contralateral breast cancer or multifocal breast cancer, we detect it right away and we can do the necessary biopsies, and we can do the auxiliary staging with ultrasound at the same session as a sort of a one-stop shop modality. Now, we at our hospital have the luxury as well with our colleagues from the Department of Pathology that we have 24-hour diagnostics for breast cancer biopsies, and we also decided to have multidisciplinary team meetings every day during lunchtime. In fact, we can offer these patients within one working day not only the biopsy results of everything that was observed on contrast-enhanced mammography, but also discuss them in an MDT meeting and have the whole preoperative plan already available for them within 1 or 2 working days. The most important thing is that you have an automated injector. It's possible to do it manually, but you need to realize that you have volumes of contrast from 90 to 120 cc's, and you can administer them manually, but it's becoming very strenuous for technicians, especially if you do multiple patients on a short notice, for example, in one morning. So the use of an automated injector eases your life a little bit, and especially the life of your technicians. Now, when administering contrast, you always have to take into account the possibility of renal impairment or hypersensitivity reactions, and the same rules sort of apply to the use of iodinated contrast agent like you are used to using at CT examinations. So your department needs to be equipped and trained for that as well, and to cope with any kinds of these reactions. Now, when you administer the contrast, you wait for approximately 2 minutes before you do the mammographic positioning. And the mammographic positioning should be performed in the similar fashion as that your technicians are used to. So this is an interesting case of a 67-year-old woman who had prior breast surgery because of an invasive carcinoma on the other side, for which I will not show at this point. She presented herself with a palpable mass in her other breast after some years, and because of a suspicious character of the palpable finding, we immediately did a contrast-enhanced mammography in this case. And I will show you here the craniocaudal views of the right breast only. So here you have the low energy image of that case, which shows heterogeneously dispersed dense fibroglandular tissue with actually no really circumscribed masses or architectural distortions. You don't see any pathological calcifications, but when you look at the recombined image, which shows you areas of contrast capture, you actually see an ill-defined heterogeneously enhancing mass popping up over there, which was apparently obscured by the dense fibroglandular tissue, and that really helps us in detecting the breast cancer, not only in terms of detecting the breast cancer, but also establishing its true size. So in this case, we have a 57-year-old female who was recalled from breast cancer screening because of a very small, rather well-defined round mass in the outer part of the left breast, which wasn't present at prior mammograms. Because of her recall from screening, we immediately did a contrast-enhanced mammography, despite the fact that she had rather low density of glandular tissue, but that's standard practice in our hospital. And you don't see any enhancement occurring on the recombined image. In fact, in this case, you see an absence of enhancement. You sort of see a black void appearing over there. And this is a typical example of what we have defined as an eclipse sign. And this is very suspicious or very suggestive of a simple cyst. And it doesn't even require additional ultrasound to check it. This can be immediately dismissed. We didn't see any abnormalities on the contralateral breast, and with the high negative predictive value of contrast-enhanced mammography, we know that it is safe to assume that this patient can be discharged immediately and return to breast cancer screening in 2 years' time. Now, in this case of the 62-year-old woman who was treated with neoadjuvant chemotherapy, again, the series of images on the left side of the monitor is the baseline examination, in which you can clearly see at the 6 o'clock position irregular shaped mass, which is also heterogeneously enhancing on the recombined images, and the image after 4 cycles of chemotherapy, which is this set of images. You can actually quite clearly see some kind of response to therapy, which increases further at this set of images, which is at the end of the chemotherapy treatment. Here you absolutely see no residual enhancement, only a faint amount of residual enhancement, but no abnormalities anymore on the low energy images, suggesting a good response to therapy. The first one is that it always takes a little bit of a leap of faith when evaluating the images. You're not familiar with these kinds of images, so if you still feel the need to confirm your findings with a breast MRI, I would have a very low threshold of doing the actual breast MRI, but then collect your cases and review them at a later stage. You're familiar with what you see on breast MRI, and then you can sort of go back to your contrast-enhanced mammography examination and see how it looks like on those images. That really helps you in building confidence in this technique. Now, the other thing is very practical. Sometimes there can be the occurrence of contrast contamination. You have these small specks of contrast on your recombined images, which can sort of mimic microcalcifications on your low energy mammographic image. Now, you can deal with that very easily. We in our hospital decide that we either wear gloves doing the manipulation of the contrast to prevent any kind of contamination, or you can make it even more easy to have two technicians in the room. One is handling all the contrast and all the contrast vials and everything that's associated with that, and the other technician does the positioning when the contrast is administered. And in that way, you can also prevent that there is contamination of contrast within the breast. Well, I think the most important take-home message is that contrast-enhanced mammography is here to stay. It's not a research tool anymore, but it's a really dedicated breast imaging technique that has now found its way to clinical practice. And it's our job as a radiologist to really figure out where the strengths and weaknesses lie of this technique. But I'm fully confident that it's a technique that's here to stay.